आगे भी चल
नेक्स्ट
रहा
और इस
है पॉइंटर का किधर से दिस वन
Bismillahirrahmanirrahim. Thank you very much for the kind introduction and invitation. And I'll try my best to complete my talk in next 10 to 15 minutes. And I'll make it very practical and case-based so that everyone will go through, and definitely I'll try my best to take the questions at the end of my talk. So let's start. 56-year-old female, she had presented to us, and she had no known major coronary artery disease, risk factors like ischemic heart disease, of ischemic heart disease. And there is no history of any structural heart disease, thyroid issue, and other comorbidities. She had documented symptomatic 4 episodes of paroxysmal atrial fibrillation for last 2 years, despite of taking tablet bisoprolol and tablet flecainide with a dose of 100 milligram twice a day. So this was the ECG which was recorded during each episode, and everyone can appreciate that there is no repetitive distinct P waves and there is irregular RR intervals, so it's fulfilling the ECG definition of classical atrial fibrillation. And we can appreciate the ventricular rate is not that much fast because the patient is already on tablet flecainide and bisoprolol. So this was the ECG which was recorded after restoration of normal sinus rhythm. And we can't appreciate any other significant abnormalities, especially any evidence of right atrial or left atrial abnormalities and left ventricular hypertrophy. So now if we just review our case and we just put it what the guidelines say about this patient, we know that our patient has no structural heart disease. And the patient classified in a setting of a paroxysmal atrial fibrillation because every time the episode lasts less than 7 days, and sometimes it was cardioverted pharmacologically, and sometimes it's spontaneously reverted to normal sinus rhythm. So if we just take the antiarrhythmic drugs, as we have taken in this case, then it's a class 1 recommendation with a level of evidence A. But if the patient is refractory to antiarrhythmic drugs, either one or more than one, and you just go for catheter ablation, either with a RFA, AF ablation, or a cryo method, then it's a class 1 recommendation. But if you just take, based on the patient's choice, directly to the catheter ablation, even then, the evidence support that it's not that much inferior, it's superior. So in any case, especially we have to take such kind of cases which are refractory to antiarrhythmic drug therapy, and they have frequent episodes of atrial fibrillation for catheter ablation. So now that's very, very important. Based on the pathophysiology of atrial fibrillation, we know that pathophysiology of atrial fibrillation based on substrate of the atrium as well as the triggers. But pulmonary vein isolation is actually the cornerstone of AF ablation. And those patients who are having paroxysmal atrial fibrillation or early persistent atrial fibrillation, more than 90%, the triggers, they are actually contained within the pulmonary veins. And we know that the myocardial sleeves, they are extending beyond the antral veno-atrial junctions up to the left atrium. So if you just review the 2017 HRS-EHRA consensus statement, electrical isolation of all the pulmonary veins is recommended during all AF ablation procedures, class 1 recommendations. The same is true in 2020. And if you just choose the other ways of CAFE and other lines, especially to deal with long-standing persistent atrial fibrillation, that's the 2B recommendation. So in a paroxysmal and early persistent atrial fibrillation, triggers are the main contributors of AF, while in long-standing persistent atrial fibrillation, the atrial remodeling and the substrate that contribute to the rotors and re-entry and all those kinds of pathophysiology of the atrial fibrillation. So it's very, very important to know that in our case, more than 90% chance that we are dealing with pulmonary vein triggers as a cause of paroxysmal atrial fibrillation. So now we know that there are 2 ablative methods that are known to many years, RFA and the cryo balloon ablation. You know, this is the most commonly used method. And I know that it's highly operator dependent, and it has a very, very long, you can say, learning curve. But believe me that this is the gateway to all kinds of complex arrhythmia. If we don't have a skill to deal with RFA, AF ablation, then definitely we will miss a lot, especially to deal with other kinds of complex atrial as well as the ventricular arrhythmia. So the skill of RFA is also very, very important. But we know that it's highly operator dependent, it has a very long learning curve, but when we have to go through. But once we compare it with the cryo balloon ablation, it's the second most commonly used method, and nowadays, especially for the paroxysmal and even for the early persistent, it's the, you can say, method of choice as a, you can say, first commonly used method, I'll say, for paroxysmal atrial fibrillation. Single short device procedure, very short learning curve, and the procedure time as well. And we know that the pathophysiology of cryoballoon ablation is actually the extracellular and intracellular ice formation, and rewarming will lead to recrystallization and more cellular damage, and ultimately necrosis and apoptosis, and ultimately you will get a very well demarcated lesion as compared to the lesion that has been done through thermal injury. So it's our common approach for all patients where we are taking these patients for the cryo balloon AF ablation, pre-procedural imaging. It's very, very important, especially to exclude all kinds of intraatrial septal aneurysm, any kind of shunt, any kind of other structural abnormalities. And it's again our common practice just to exclude the left atrium and left atrial appendage thrombus. And it's mentioned in the literature that it's very, very important to also look for left atrial appendage emptying velocity that will guide the physicians what's the risk of recurrence, especially in the future. The same is true for the CT image, just to look for the number of pulmonary veins, their diameter, either the patient has left common trunk, and that again has a different definitions. And what are the number of pulmonary veins, what's the LA size, any evidence of left atrial appendage clot, and all those things. So pre-procedural imaging is very, very important before you take these patients for the ablation. So this is the technology which is being used to deal with paroxysmal atrial fibrillation patients. This is actually the cryo console, and this is the nitrous oxide refrigerant, and here these are you can say, equipments which are being used for paroxysmal atrial fibrillation through cryoablation. This is actually the cryo balloon, which has inner balloon and the outer balloon just for the safety purpose. And this is again 12 French steerable unidirectional sheath, which is used to track the balloon and the other guide wires to engage all the pulmonary veins in a very clockwise fashion, starting from the left superior, left inferior, right inferior, and the right superior pulmonary vein. And these are some important parameters to look for, especially just to look for the durability of the pulmonary veins in the longer term. What's the nadir temperature once we have started the ablation? It should touch -40 or below that. And what's the rewarming temperature? And these all parameters are very, very important to look for long-term durability of the pulmonary veins. And this slide is very important for especially those who are doing these cryoballoon ablations. So this is our common steps of doing this cryoballoon. Normally we took 3 right-sided venous access, one for to go for transseptal access, and then just to exchange with the flex sheath. And the second one is used just to position this decapolar catheter within the CS, and later on it is used for the phrenic nerve capture as well. And the same is used just to deal with the vagal reactions, which is common, especially once we are dealing with the left superior pulmonary vein. And this is, we know, we almost do this transseptal puncture, that's the fluoro-guided. And we commonly used RO and LO view to deal with. Because now these are the anatomical landmarks. Previously we used the pigtail catheter as an anatomical landmark apart from the CS catheter, but currently we are using the HIS catheter, which is actually representing the caudal portion of the proximal aorta as a guide, just not to inadvertently damage the proximal aorta. So the aim is just to go for antero-inferior transeptal puncture, just to accommodate and to have a more room for positioning of the balloon. So normally we use RO just to position, yes, this is anterior and not posterior, and the same in the LAO view. And once we have the transeptal puncture and once we have the wire within the left superior pulmonary vein, then we just exchange the whole system with the flex sheath, and that's a unidirectional as RA said. And then we just engage with the, this is actually a recording multipolar achieve catheter, which will record the signals from the left superior pulmonary vein. Once that's there, it will not only record the signals, but it will help to anchor, or especially it will facilitate to position the balloon close to the veno-atrial junction, especially the left atrium. Once that's there, then we will start the freezing method. So we will use this technique in a clockwise fashion, as I earlier mentioned. Once we will go for the left superior pulmonary vein, then left inferior pulmonary vein, and then right inferior, right superior. And once we will deal the right-sided veins, then we will position this decapolar catheter within the right-sided subclavian one, just to check for phrenic nerve capture, because this is the more common complication that is known with the cryo balloon technology. So it's a very, you can say, short procedure in a way that you will take this cryo balloon inflation only for 4 minutes. And if you just complete the whole cycle, that will take only 20 to 24 minutes just to complete the whole, all pulmonary veins just by this freezing method. So now, this is the way: left superior pulmonary vein, left inferior pulmonary vein, and this loop, actually multipolar achieve catheter, will record the pulmonary vein signals. And by this, we will come to know, yes, once there is a disappearance of the PV signals, within 60 seconds, that will guide us that there is clearly isolation of that particular pulmonary veins. And the same is true for the right-sided. And now we can appreciate that the CS catheter, which was positioned for the left-sided pulmonary veins in the CS, but now it has been positioned on the right subclavian just to look for the phrenic nerve capture during freezing of right inferior and the right superior pulmonary veins. So now, this is actually the dosing protocol, but that's not relevant to the cardiologist, but that's very, very good to know, especially for the electrophysiologist. Total time of pulmonary vein isolation, if that's less than 60 seconds, then just we will extend the freezing time to 2 minutes only. And then we will look for entry and the exit block. This is the most commonly used method just to look for the durability of the pulmonary vein. But if the time of pulmonary vein isolation is between 60 to 90 seconds, then definitely we will go for a bonus lesion up to 2 minutes more. So normally 4 minutes, 2 minutes, around 3 minutes and 4 minutes. And if we fail to find the pulmonary vein signals, then 3 minutes cryo application will be enough, and then we will look for the entry and the exit block. And this is the final stitch. Now the question is, what's the clinical evidence? It's very, very important to know. There's the STOP AF. This is the pivotal trial that was published in 2013. And around 70% freedom from AF at 1 year compared to drug therapy. And this evidence is growing, especially extending 2014 to 2015. 80 to 90% single procedure freedom from atrial fibrillation, atrial tachycardia, atrial flutter after 12 months. So very, very important. And now we all know about the FIRE and ICE trial, which actually has compared the cryoballoon technology with the RFA AF ablation. Cryoablation is as effective as RF ablation with shorter, more consistent procedure times and low overall incidence of serious treatment-related adverse events. The same is true, especially guidelines for the management of atrial fibrillation, European Society 2016, 2017, 2018, and even this technology is also recommended for early persistent atrial fibrillation as well. This trial has been published in 2020, STOP Persistent Atrial Fibrillation Trial. So 54.8 freedom from all kinds of atrial arrhythmias at 12 months, with drug refractory symptomatic persistent atrial fibrillation with low adverse events. So this is the last slide. It's very, very important to look for, especially this is the takeaway message for all the cardiologists, that one has to refer these all kinds of paroxysmal atrial fibrillation cases and early persistent atrial fibrillation just to go for early AF ablation either through RFA or a cryo. These all these three trials demonstrate that cryo balloon ablation as a first-line rhythm control strategy has an acceptable safety profile. It's very, very important to know. Thank you very much. Last one?
Last.
Hello. 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 Sorry, Manan, that was a wonderful lecture, I just joined a bit late, But obviously, the purpose of you inviting us was that you should become more, we should, as interventionalists and non-EP specialists, become more oriented with what you are doing, First of all, as you have showed that this cryoablation is better than radio frequency, What's the experience in Pakistan? Have we been doing radio frequency ablations earlier and now cryoablations? And what's the experience at PAC? It's just cryoablation now or any radio frequency, or you are not doing radio frequency anymore, number one. The second thing is, obviously it's either the paroxysmal or persistent new onset. So what about a single or two, what sort of a patient should be referred to, And what, that's the basic thing. Which patient to be referred? We see so many of atrial fibrillation patients. It may be a single episode. And the further confusing thing was that paroxysmal atrial fibrillation refractory to medical treatment. So please, I want to know the algorithm. It should be the first episode or persistent? And first of all, should the drugs be tried and then sent to you? Please just brief me on that. Clarify on that. Thank you.
Yes, sir. First, coming to your first question, that we are doing both RFA AF ablation as well as cryo balloon AF ablation in our institution. So our selection criteria, especially for the patients, we are only taking those cases who are actually having paroxysmal atrial fibrillation with refractory to antiarrhythmic drug therapy. Especially, we are using flecainide because we are dealing with a normal heart. They don't have the coronary artery disease with the name of Tembocor. So the choice whether we have to go for cryo balloon freezing technology or a heat, especially we are those patients who are having concomitant classical typical atrial flutter apart from paroxysmal atrial fibrillation. So our choice, especially in those cases, just to go for RFA AF ablation with CTI line to deal with CTI dependent typical atrial flutter. And for those patients who are having paroxysmal atrial fibrillation refractory to antiarrhythmic drug therapy without any documented atrial arrhythmias, we are taking those patients for cryo balloon AF ablations. As far as the type of patients which you are which you are referring to us, especially those patients who are having no structural heart disease, mean no obesity, not, you can say, big atria of size of more than 50 mm, and uncontrolled risk factors. In those cases, the arrhythmogenic substrate and the pathophysiology is altogether different, and the chance of recurrence is very high. So we are taking only the paroxysmal atrial fibrillation with normal LSI is refractory to antiarrhythmic drugs.
How many episodes?
At least 2 to 3 episodes on medication. And they are very, very compliant and with no other, you can say, comorbid conditions.
Does LA size, have any impact on your CRT?
100%. If we just review the literatures, they are taking the LA size, not the LA volume index. But we are taking, if we just review our 20 to 30 cases which we did, especially in our institutions, the LA size range was between 35 to 45 mm. We were not taking those cases who are more than 50 mm, especially with you can say, big atria and the structural heart disease, uncontrolled hypertension, left ventricular hypertrophy, and all those things. So we have, once we are doing the procedures, now we have a number of referral cases, and we have too many paroxysmal AF cases which are coming to us for AF ablation. I am surprised. So once we are not doing these cases and they were on the medications, no one was referring to us. The same is true with the SVT cases. Once you are not doing the ablation, no one will refer to you. They will only keep on Aquilan and the beta blockers and all those things. Once you have a very good results and you are safe and you are taking those patients based on class 1 recommendations, the results are very good.
So, sir, sorry, just a quick comment.
Yep.
Sir, sorry.
You know, that was the purpose actually of we coming, you know, so
Sir,
that we get more oriented.
Well, Manan actually answered it quite rightly, but just to answer your first question, which was, do we do the RF ablation, conventional RF ablation, and vis-a-vis now the AF ablation via cryo. So those of us who got their early training, like myself and Aamir in the West, so this is how this AF ablation evolved. So it started from this conventional RF ablation, but the purpose was never solved, and the success result was never good. At the best, the success was 50 to 60%. And once AF settles, AF begets more AF. And once this starts the remodeling and so on. So the concept now is that with this vein isolation, because we all know the substrate lies in paroxysmal, the substrate lies in the pulmonary veins. So if you go in and electrically isolate the veins and do it as early as possible in the life of a person, the chances are that you will prevent his LA from being a diseased LA and a remodeled LA. So the earlier is the better.
Earlier is the best.
That is the theme. That should be the target. And this is, we are talking of paroxysmal AF, obviously non-valvular AF. These are the two substrate. So I was just this morning, I was sitting with Suhail Tufail Saab, and the same question he asked me. And the same answer I gave him. So in this case, paroxysmal, the earlier the better. That's what the theme is. The success in good centers with vein isolation, whether do it by point or by cryo, especially cryo now, is 80 to 85% at best in the first go. But then most of the centers, if you do it second time, they almost achieve a cure of 100%. So message for you, sir, is if you see a patient with AF who's got a paroxysmal AF, the best is refer him to an electrophysiologist and get it ablated.
Professor Azmat, just one question. You told us about the cryo ablation. Is it superior to radiofrequency ablation?
So there were no, in my experience.
Non-inferior. Cryo balloon is non-inferior to RF AF ablation, as I earlier mentioned, because we are just isolating the pulmonary veins.
But is it more safer than?
Yes, definitely.
And what is the frequency of pulmonary vein stenosis? Like you are isolating the area around the pulmonary veins. So what is the complications of pulmonary vein being affected?
Right, sir. So the reason RF, this cryo came in is because of the theme that if you catch it early, catch the veins, the chances are that you will suppress the disease. So this is the logic behind doing this pulmonary vein isolation. Preferably by cryo now is because of its less complication. And the biggest nightmare was, so in my experience, I saw 3 patients with PV stenosis, two in the West and one somewhere else. So Aamir will also bear me out. That was the major worry, other than these esophageal issues, which led to sort of downside of this RF. And the only safety with this cryo is that you don't get these dreaded complications. The only one thing is the phrenic nerve, which you can avoid during the procedure. So the message is, AF, PAF, non-valvular, normal LA size, the earlier the better.
Dr. Manan?
Yes, I just want to add one thing. Here you can see the position of the balloon. It's not within the pulmonary veins. It's actually at the antrum. So there is no risk of pulmonary vein stenosis. And the second thing, now this method is obsolete now. Now they are doing wide area circumferential ablation. They are not doing the point by point ablation. They are just isolating all the pulmonary veins just by doing the RFA AF ablation. That's extending from only at the antral site, not within the pulmonary vein. Previously, they were doing the isolated pulmonary vein isolation, but now they are doing wide area circumferential ablation, mean the ablation line is actually covering all the pulmonary veins in a way that it's not touching the proximal pulmonary veins. So that's the reason now there is no risk of pulmonary vein stenosis either with cryoballoon and either with RFA AF ablation, because the method is altogether different.
So one point is that I agree with you. So wide area circumferential ablation is good, but your balloon is circular and that area is not circular. So you do tend to get areas where you will maybe not establish exit or entrance block. So my concern is, or with your redo procedures, let's say they reconnect and come back, do you use RF to plug it? Because you don't have a, or do you use a cryo ablation point to point?
Sir, for redo cases, there are always reconnections. So the RFA AF ablation is the best one because there are reconnections of either one of the vein. It means that then one has to go for a voltage map and the activation map just to know where are the reconnections. So RFA touch ablation will help in those cases rather than just to go for cryoablation in a second setting.
So for any atrial fibrillation program, you need to be adept at doing what you called a very resource incentive and skill intensive exercise. So if you're doing cryo on all patients and then you have to go in and find those gaps and retouch with an RF,
one has to
then it becomes a challenge.
Yes.
Dr.
And one
Manan,
has to have the skill of this thing just to deal those reconnections as well.
Dr. Manan, just expanding on Zubair Akram's question, you mentioned the LA size and not the LA volume index. Is it the lack of data?
I am not mentioning, it's actually mentioned in the literature. Ideally, LA volume index should be there.
That should be there.
That's the more quantified mean of knowing overall
because
LA.
LA can expand in
Yes.
different directions. And the other thing is, can you people devise kind of major or minor criteria? Because if somebody is having one episode a year and LA size or volume index is normal, should we refer them to you?
Every arrhythmia case should be referred to electrophysiologist, whether that is atrial fibrillation or not atrial fibrillation. Thank you very much.
Last question. Let's say if the Chadwick's case more than 2.
Yes, sir.
Yes, and the patient has been cryoablated. What about anticoagulation therapy? Should it be discontinued or continued?
Anticoagulation, especially Chadwick's equal to or more, definitely we will opt the anticoagulation, and the procedure type will not affect the duration of anticoagulation. Anyone who has a Chadwick's of 2 or more than that.
After a successful cryoablation?
Yes. The procedural success will not affect the duration of anticoagulation for rest of the life.
Okay,
That's wholly based on Chadwick's.
So it's a very interesting question. I think because हमने ablation शुरू की थी in order to get rid of anticoagulation. So we now know that atrial fibrillation is a risk factor for, and it's not causative of a stroke. So ideally it should continue, but people have looked at, with implantable loop recorders, they've looked at data, and if after an ablation for 1 year or more, they do not have any paroxysms, and your borderline kind of chads, people have suggested that you can go off anticoagulation, but again, that's not guideline.
Some of them claim that 2 months is enough, is it?
So again, as I said, that it's not mainstream data, so this is just peripheral thought. And the reason that 55 millimeters is being taken off, it's the classic Hassie-Gear data. They would not measure volumes at that time.
Thank you very much, sir. So my next speaker is Professor and Head of Cardiac Electrophysiology at Ziauddin University Hospital, Karachi. He is currently President in Pakistan Heart Rhythm Society and also country representative of APHRS. It is my honor to invite Professor Aamir Hameed. The topic of his talk is failing heart, role of CRT, tips and tricks.
Thank you. It's so interesting to see actual good questions on atrial fibrillation, and if the area is still vague actually, we can ask even more questions. So I'm going to talk about something which is well established, that is the role of CRT, cardiac resynchronization therapy in a failing heart. Okay, nothing to disclose. So this is a run-of-the-mill case that you'll be seeing, a 57-year-old man, shortness of breath on exertion, has 2-vessel disease, has had MIs, and now after PCI is burnt out and having an EF of 30% on optimal medical therapy, and has risk factors. Creatinine is up a little, and his ejection fraction is static at 30%. He is NYHA 223. His ECG shows a left anterior hemi block and left bundle branch block with a wide QRS duration of 160 milliseconds. His chest X-ray shows no signs of heart failure, and his baseline pro-BNP with this clinical condition is 4,000. So this is the run-of-the-mill patient who comes in. So can we do something more for this patient? Surely we can do more for this patient, and this is evidence. Now we are talking mortality benefit. We are not talking symptom relief as we do for most of the coronary or cardiac procedures. So if we have, N by HA2, EF less than 35%, QRS duration is more than 130, and you have sinus rhythm if the QRS duration is more than, actually quite wide, which is more than 150 milliseconds, then it's a class 1 indication, and this is where our patients falls for a CRT ICD implant. So CRT is one of the most important therapeutic advances in recent years in this subgroup of patients who are really, have bad outcomes. Once you put in CRTs, there is a 60 to 70% responder rate. That is, you have to choose your patients and do a proper job. Otherwise, there are about 30% people who will just have a metal box inside and do nothing for them. And evidence of efficacy of CRT improves outcomes in carefully selected patients. So our selection, just like in atrial fibrillations, the selection has to be meticulous, and I always feel that the implanter should not be the one who, or the ablator should not be the one who is, kind of preparing the patient for this outcome. Okay, so planning for a successful procedure is sleep well, and I've realized that when I've gone with less sleep, procedures always go long. And when our procedure goes long, it is basically subjecting the patient to a lot of radiation, and yourself and your team to it as well. So the patient should be first on the list if you can. Pre-brief the team, sit and talk, define roles, expect roadblocks. Working in a venous system is very different from working in the arterial system, because a lot of times you're going against the flow. Plan to troubleshoot, choose closed loop communication. There are a lot of team members when you are working inside, and therefore it is very important that when you say something, they repeat back that they're going to do this. Know your resources. You may not have a certain amount kind of sheath that you would require if you are so always make sure that you have all of that. Ask for help whenever you need. Call in another operator. Ask your assistant. There's always good suggestion. Minimize discomfort of the patient. Meticulous sterilization is key, and I think that's probably where I should stress most. So make sure once the doors are closed, nobody comes in. It's a surgical procedure. Hemostasis is important. People work with blood dripping down the sheets. Shouldn't be that way. And debrief at the end to improve your future operations. So because this is a long procedure and you have long sheets, and your lay is such that you need to make sure that you have a table which is height adjustable, and so you stand like this if you're doing a right-sided procedure, and if you're doing a left-sided procedure, which is the norm, you should be standing like this. Operator should be here, assistant should be here, and that is how this way the things don't kink and they don't fall off the table. So I'm going to show you a lot of pictures. Okay, so these are our standard incisions that most of the implanters would know. I'm going to skip this. This left subclavian, that is where we work, is in a standard position, which is where the second and third lap confluence is. That's where you have it every time. So always poke under vision, because you're going to poke 3 times. Your pokes should be separate from each other, otherwise the devices will interact, and that is not a good thing. So that is where you do it, where the first rib is crossed by the clavicle, and you should not cross the medial. If you don't cross the medial border, you will not drop a lung. So in my 15 years, I've dropped 3 lungs, and those were cases. One had a scoliosis, one had apical TB, and it was my fault because I had not worked them up well. But if you're using, even if you don't injecting dye and just looking at landmarks and going in, you will get the subclavian every time. So have to be clean with the insertion. Now it is very easy. If your angle is not good, you can puncture the lung and get a pneumothorax. If you have done that, if air comes into your thing, then start meticulously looking at the apex for pneumothorax, which starts building up. Similarly, if you are doing a redo procedure, and it depends on multiple leads and the lead diameter. If you have a lot of leads in a vein, when I was training about 15, 20 years, they used to say that you can have up to 5 leads. Now, with extraction systems, we are extracting leads, which is the way to go. But clearly, if you have more leads, chances that your subclavian will be blocked are significantly high. So even then, Professor Seth Worley says that always go in and give a local injection, and you will see a trickle. And if there's a trickle, go with a slimy wire. If it passes, then you can go and do an angioplasty. And so have your interventional colleagues as close to you as possible. But remember that all angioplasters are not venoplasters, and veins are very, very different from arteries. So whenever you call in a colleague, make sure that the colleague is experienced. I've done that once and I regretted doing that. So this is the coronary sinus, a structure which drains the entire heart venous flow into the right atrium. And this is the ostium, and then you have the branches, and these are the branches we are interested in. But what we fail to recognize is that there is a valve here, which is the Thebesian valve, and there's a Vuissens valve up here, and I'll show you other views. So it is present in about 80 to 90% of cases, and a lot of times we get trapped over here. And I'll show you images of how we do that also. But in only 20% of the patients, this becomes hemodynamically or at least tactically operational. So we are lucky that it doesn't happen the other times. This is an anatomical structure showing the Thebesian valve. So we have to go and cannulate this structure at the mouth of the ostium. And this is the coronary sinus from underneath. This is the inferior surface. And this is the left atrium, left ventricle, and this is where the coronary sinus. When it goes into the great cardiac vein, that is at the mouth of this, you have the valve of Vuissens. The Thebesian valve is here. And there is another structure that I will show you later on also, is the Eustachian valve, which is the valve that separates the opening of the inferior vena cava from the tricuspid valve. So that valve also sometimes hinders your catheter from going into the coronary sinus. So these are the tools that we use, long sheets, and sometimes you need long curves. This is something that I have not used because I've not had these, but if you have this structure, it is just like an angioplasty set up with a delivery sheath, with a sub-selector, and with a vein selector. If you have this, life becomes very easy. But remember, in a private setup, the more you add to the armamentarium, the cost goes up, and the cost is significantly higher already. Okay, so height adjustable table layout. I've shown you high-grade before the procedure because there's contrast, excess of subclavian vein I've described, and of course excess of CS. So these are broken up the tools. These are the vein selectors, and this is the whole contraption that I've shown you. Using this syringe, which we use for angioplasty, is better because it's stiff-walled, the plunger is reinforced, and the inner diameter is less. So physics tells you that you will use less force and the injection will be forceful. And more, because this injection is going into a vein which is, actually you're going against the traffic. It's not the artery where you will give a puff, whiff, and it'll go down. This you are going against. So we have to be careful, and a lot of times now people are not using balloons, occlusive balloons, because they cause complications. So they're just using sheaths. So we need to have this kind of syringe if possible. We don't have the luxury always. Okay, so for cannulation, I'll show you, in fact, how to do this. So there are two methods. One is you use the delivery sheath and you use the coronary sinus catheter. And because we are electrophysiologists, we use the coronary sinus catheter all the time. So I use this technique, but a lot of times when you cannot use this technique, you can use an Amplarts or a multi-purpose catheter injecting dye and going up. So these are two methods, and they have kind of looked at the fluoroscopic time. If you look at the fluoroscopic time, so it's 20 minutes for the where they're using dye and the normal coronary catheter versus EP. This is 8 minutes more. So if you're putting 20 more devices, 1.5 घंटे की radiation आपको ज़्यादा मिलेगी. So you can actually save on this, but depending on आप किस में comfortable हैं, you should do that. So this is how we do it. We go in from up here, go into the tricuspid, across the tricuspid valve, then counterclockwise and we pull back. This is the Eustachian valve. अगर हम इससे पीछे गिर जाएंगे तो we will never be able to go into the coronary sinus. So clockwise, pull back, it drops into this, and then you check with the dye and then you can go ahead. So this is a Thebesian valve. They have injected dye. This is an LAO view, and it's a slit-like opening. So what they did was they went in from the femoral, they put in a coronary sinus catheter, pushed it through, and once they had a little room, then they put the sheath through and injected dye. So this is challenging. And if you cannot bypass this, then you are in trouble. Now once you have bypassed it and you inject dye, this is where the valve of Vuissance is. And this is blocked. See, there is going to be a coronary sinus over here. There will be branches over here, but you cannot see in this view because of the valve of Vuissance. So an operator needs to understand. This is balloon occlusive venogram, and you can see these branches. So posterior branch, this is the posterolateral area and the anterior branch. So anything in the lateral territory, if you can pace it, is good enough. Sometimes a nightmare in the lab is when you have a left persistent SVC. And it's okay if you have a left persistent SVC and a right SVC as well. You can go from there. But I implanted one device in which there was nothing on that side, which is again very rare. So you go down the left and you have to then search here, which becomes very, very challenging. And I'll show you. These are classic cases that I've taken from the literature. If you see, this is the left subclavian persistent vein. This is an LAO view, and this is a very capacious left coronary sinus. Now, if you look over here, they have actually gone and found the great cardiac vein above the Vuissance valve. And when they inject dye over here with an occlusive balloon, you can see faint filling of tributaries, which otherwise you cannot see. And you usually send these patients to the surgeon, but if you've done that, you can actually manage to go in and implant. So it requires time, patience, and this is the same device, sheaths and sub-selectors that I was showing you. And these sub-selectors, if you have, they can actually help you cannulate the vein, and then you can advance the sheath on the and then the lead can be delivered easily. Otherwise, if you cannot turn this sharp bend, any angioplaster would know if the stent is not going, then you are in trouble. So this is a case where they injected dye, and immediately there was extravasation of dye, and then an aneurysm formed, and when they re-injected it they actually got perforation, and you can see dye in the pericardium. So you have to be very careful when you are doing this. Valve of Vuissance can be a nightmare, so appreciate its presence over there. Now sometimes we cannot find a vein, but we can find a trickle, and if you give a good injection and if you can find a trickle, you can advance a wire which can come back through collaterals into the main coronary sinus. It can be snared and held over there, and then you can, and this is Seth Worley's technique which he has used. And he hardly ever leaves anything, and he can implant, but he's got great skill. So this is one way of doing things. The other thing is that if you have an acute takeoff, what you can do is either use the telescoping mechanism that I showed you earlier, or you can advance the coronary sinus catheter, and so that the vein can straighten up, and you can actually then go in and implant the lead. This is a normal left subclavian vein. Okay, my time is up. Implant. So this is just a picture to show you this. And this is another nightmare, that is if you have stenosis over here, you can actually do balloon inflation. I'll just take 1 minute more. So, and you can actually open this and go in through this and implant. So don't give up when you have when you have a stenosis. This is straightening of the vessel. Right-sided, a lot of times when you're doing a redo procedure, you have to go to the right side. Remember, on the right side, it's a very sharp takeoff, and because it's a shorter distance, your sheath is outside, and the sheath is not supported. So you can use an inner telescopic braided subselector type so that you can torque it, or you can use a larger bend. And sometimes what I've done is, I have actually implanted from the internal jugular and tracked the device under the skin into the left pocket. But these are for redo procedures, but needs to be understood. And sometimes you have to do the right because you don't have the left, luxury of the left. Okay, this is just a right-sided procedure. This is a nice image. And this is something that, this is the paper over here. I've given the reference of Sidrus. When you cannot implant and the patient has a very high surgical risk for an epicardial, what they've done is they implanted in the right ventricular outflow tract a bipolar lead and used this, and even they showed that there was significant improvement in outcomes. So this is a paper that you can refer to in interventional cardiac electrophysiology. About 2.17% complication in good hands. So this is a study of 138 patients. So they had coronary dissection in 2 and dissection plus tamponade in 1. So it doesn't happen, but once it happens, you must look at it. So in conclusion, CRT is one of the cornerstone therapies of patients with heart failure. I'm not talking of symptom relief only. There is symptom relief. There is mortality benefit. However, many obstacles lie ahead of successful and complication-free LV lead implantation, newer tools, refined techniques, but take the cost up. If you have it, be familiar with it and use it, and understand the anatomy of the coronary sinus. And remember, you are going against the traffic, so have your seatbelt on. Thank you.
Dr. Aamir, just a question. You have very nicely elucidated the steps of how you do, but the questions for non-electrophysiologists is when to refer.
Yeah, so
I think life has become more easier if you define the left bundle branch block duration. Is it the only criteria now, or there are other things?
No, so so it's a very well-defined criteria. There are 2A, the chart that I showed you actually had an arm on the other side also. Previously, we were not even recommending in atrial fibrillation, but now in atrial fibrillation also they are recommending. I just went with a hardcore class 1A indication. We are not even getting those patients. So the first step would be to have it very clear, no murky waters, refer patients who have an EF of less than 35%, a QRS duration of 160 milliseconds. Now, guidelines suggest that even above 120 milliseconds, if your functional class is bad, like your NYHA 3, you will benefit. Even with right bundle branch block, if your QRS is wide, like more than 160 milliseconds, you will benefit. But I don't want to confuse issues over here. I just want you to take a person who is burnt out coronary artery disease, you've given him optimal medical therapy for 90 days post-procedure, and he is not recovered, and he has a left bundle branch block which is 150 or more, and an NYHA of 2 to 3, he is 4 में जाके problem होती है, उनकी longevity heart failure की वजह से कम हो जाती है. You need to be alive for at least 1 year to have mortality benefit. So earlier, and this clean indication. But anyone who has a left bundle branch block, let's say, which is 130 milliseconds and an NYHA 2, do refer. And a discerning electrophysiologist will tell you whether this guy needs a device or not. Now, the other thing is, if you have non-ischemic cardiomyopathy, which is a big chunk, they don't have a well-defined scar. So their CRTP is indicated, but maybe you can take the ICD component out and drop the cost by about 1 million. So that can be done. But for people under 70 years of age, even in those patients, the ICD has a small role. But CRT will go for all those patients who have a left bundle branch block, conduction delay, down ejection fraction, and symptoms.
You do recommend, like if somebody is just developed MI and ejection fraction is about 25%, broad cure is complex, a guideline-directed medical therapy should be tried for how long? Or should they be referred right away?
So, an excellent question. Now the issue is, in the West, they have the life vest. So if you have an MI, we have the luxury to keep you for 90 days is an arbitrary number that was decided by the researchers. It has got no scientific evidence. ICD जब डालते हैं, the first shock for primary prevention, when you have not had a VT, the first shock generally comes after 1 year. So in 90 का cut off is हमारी मर्जी है. I was a researcher, मैंने 90 डाल दिया. But the real threat is that in the first 40 days you will become unstable, and if you don't have the life vest, what to do? अब मैं उसको 90 दिन बिठा दूंगा. In Pakistan, where we have no 911, we do not have a life vest. So it is again for us a challenge. So I would suggest that if you feel that this is a very high risk person for an arrhythmic death, do refer early, and an earlier implant will not be going against good evidence.
Dr. Aamir, LV lead thresholds, we have often seen that after a certain time, the LV thresholds, they rise. And then at times the leads do get damaged. So quadripolar leads at times, they help us in changing the polarity and helping the patients for some time. But there are a lot of patients that I've seen that LV leads have loss of integrity. So what are the options after that? Can we reimplant? Of course, taking out an LV lead is a problem.
So I think, Tawab, excellent question. Again, preparing the patient for, so if I'm going into the territory, I should know whether the infarct was there, whether the scar is there. Because of cost, we are constrained in Pakistan. Otherwise, ideally, these people should have a CT angio to show where the posterior posterolateral branch is, and if that area is viable, you can do cardiac MRIs, you can do other stuff, and show if there is scar, I will not go there. I will go. Previously, it was suggested that you only go into the posterolateral territory, but current data suggests that any lateral territory, even if you cannot, you go into the anterior territory and look for lateral branches of the anterior vein, and even there you can get evidence. And as I've shown you in one of the slides, even if you put an extra focal point in the right ventricle, you can get benefit. So it's multi-point pacing that is important, and with the quadripolar there are 15 vectors. So even if there is scar at that point, if you take the scar as one point and you take the ring of the RV lead, ICD lead or RV lead, then you can have a larger area. And now after the quadripolar leads, I've hardly ever had. Yes, thresholds can be up, but then sometimes you have to accept. The other thing is that you send the patient to the surgeon, and you should also have a surgeon in your unit, in your institution, train him कि वो thoracoscopically बाहर से डाल दे with a low risk, a lead where he thinks is now local going on to the left side, putting in an LV lead. You can do that. Do a transeptal, go there, and anticoagulate the patient for life. It's not easy because you'll be going through the mitral valve. It is easier said than done, because people who have ablated on the left side know how difficult it is to maneuver, but that can be done as well.
Thank you very much. So my last speaker is Professor Azmat Hayat. The topic of his talk is advancements in interventional EP techniques with respect to VT ablation. Aamir.
सर थैंक यू सो मच सर. मैं प्रोफेसर ज़ुबैर एक्चुअली उठ के चले गए. उन्होंने एक वादा लिया था हमसे कि हमें ना आप इंटरवेंशन की स्किल्स दिखाएंगे. सो इस वादे पे हमें ये सेशन दिया गया. तो उनके वादे के मद्देनज़र मैंने अपनी तरफ से कोशिश की है कुछ इंटरवेंशनल स्किल्स जो ईपी की हैं लेटेस्ट उसके बारे में करें. चलाएँ सर. अच्छा हाँ जी. सो मैंने इसको बेसिकली व्हाट आई डिड इज़ कि मैंने इनको केसेस में तकसीम किया हुआ है. सो दिस इज़ द फर्स्ट पेशेंट, सर्विंग पेशेंट है, 34 साल का,
हिस्ट्री आपके सामने है, नॉर्मल हार्ट है, वेंट्रिकुलर एक्टोपीज थी, बर्डन इसका ठीक ठाक था। सो एक्टोपीज लॉन्ग टर्म अगर आप ना एब्लेट करें, ख़ास तौर पे ये इडियोपैथिक आउटफ्लो की, तो ये बजाते ख़ुद लेटर ऑन कार्डियोमायोपैथी का सबब बन सकती हैं। ये इसकी ईसीजी है, इसमें अपनी क्लूज़ हैं, देयर आर सर्टेन क्लूज़ टू बी आइडेंटिफाइड इन दिस ईसीजीज़, और ये एक इलेक्ट्रोफिजियोलॉजिस्ट की इसकी एक मखसूस सर इल्म है कि इसकी फीचर्स और शेप देख के आपको ये हम बता सकते हैं कि ये हार्ट के किस एग्जैक्ट स्पॉट से आ रही है, नॉट एलवीआरवी। एलवीआरवी में भी उसका कौन सा इलाके की, उसकी कौन सी साइट, ये नेचुरली ये इसको देख के आप एल्गोरिदम से और फीचर से आइडेंटिफाई कर सकते हैं। सो इसको अगर आप देखें, 3 क्लूज़ मैं नीचे दे रहा हूँ, आप देखें लीड 1 में, अगर आप V1 में देखें तो एक R है फॉलोड बाय S, उसके बाद डिलेड ऑफ स्ट्रोक है, और सजेस्टेड था कि ये शायद लेफ्ट कॉर्नरी कस्प से या स्लैश एपिकार्डियल। सो व्हाट वी डिड वाज बेसिकली, अगर आप यहाँ पे देखें तो ये एक CS कैथेटर है, ये काम नहीं कर रहा पॉइंटर ये। सो कॉरोनरी साइनस कैथेटर, और कॉरोनरी साइनस कैथेटर इसलिए डाला कि अगर ये समिट से होती तो नेचुरली ग्रेटर कार्डिक वेन और फिर यहाँ पे एंटीरियर इंटरवेंट्रिकुलर वेन। सो ये सिग्नल्स देखे, जुटकिंस से लेफ्ट मेन स्टेम को मार्क किया, और ये एक मार्कर है, नेचुरली दिस इज द स्पेस वेयर वी वुड लाइक टू अवॉइड एब्लेशन। फर्दर मैपिंग, eventually it was realized कि the site is in the left coronary cusp. So CS अपनी जगह पे है, ये signals early नहीं थे, left main अपनी जगह engaged है, और ये ablation catheter है। नीचे अगर आप देखें तो एक्टोपी रन हो रही है। हाँ, एडिशनल टूल आजकल आपके इल्म में है, ये 3 डायमेंशनल मैपिंग सिस्टम है। अगर आप देखें तो ये सेम रिप्रेजेंटेशन है, coronary sinus, left coronary cusp, RVOT on that side. So this is additional tool, safety, फ्लोरो का इस्तेमाल कम, और अगर आप एक साइड को मिस कर जाते हैं तो ये यहाँ पे आपको पॉइंट आउट कर देता है, लिहाजा आप इस तक दोबारा पहुँच सकते हैं। वरना अगर ये सहूलत ना हो तो आप पूरा दिन यहाँ पे लगे रहें, इट विल टेक यू मे बी hours and hours to hit the sweet spot. So this gives us added information. So now you can see इस एब्लेशन साइट पे इसकी मदद से आप नीचे देखें तो एक्टोपी, एंड देन एट सम स्टेज एक्टोपी इज गॉन। So this is one simple demonstration of a couple of things combined together and resulting in a success, achieving cure. Second, again a serving patient जिसकी ये हिस्ट्री EP 2 दफ़ा हुई, नॉर्मल हार्ट, एक्टोपी, बर्डन ठीक ठाक। इस एक्टोपी में और प्रीवियस एक्टोपी में एक फ़र्क है, आई एम श्योर जो मेरे इलेक्ट्रो कॉलीग्स हैं वो इसको पहचान लेंगे। फ़र्क क्या है कि अगर आप देखें, एक टर्म होती है डबल ट्रांजिशन। डबल ट्रांजिशन से मुराद है कि यहाँ पॉजिटिविटी थी, यहाँ नेगेटिविटी आई, एंड अगेन पॉजिटिविटी। ये एक मखसूस इंडिकेशन है कि शायद ये एक्टोपी एलवी के समिट से आ रही हो। तो पहली इंडोकार्डियल थी और ये पॉसिबिलिटी थी कि समिट। सो व्हाट वी डिड वाज अगेन द सेम मेथड, जुटकिन से इंगेज किया, वी कैन सी ऑल द कॉरोनरी आर्टरीज, दैट्स द रफली दी एलवी समिट एरिया। इस वक्त कैथेटर नेचुरली CS के अंदर है, लेकिन वहाँ पे भी जब हमने मैप किया तो इस मैपिंग सिस्टम ने मदद दी कि एग्जैक्टली स्पॉट शायद वहाँ पे नहीं है। सो इट्स नॉट समिट, बट शायद प्रॉब्ली अगेन कस्प ही है, लेफ्ट कॉर्नरी का कस्प ही है, और शायद उसकी एक मखसूस सरफेस है, शायद एंटीरियर सरफेस। तो एज यू कैन सी दिस इज द जुटकिन, जस्ट मेन स्टेम एंड एब्लेशन।
और अगर आप देखें तो यहाँ इस मैप के ज़रिए एक एडिशनल टूल हमें हेल्प कर रहा है जो हमें इसका ब्रेकआउट पॉइंट बता रहा है। चूँकि ये सिंगल फोकस है तो जब ये स्प्रेड करता है तो ये ब्रेकआउट की शक्ल में निकलता है। और डाउन बिलो यू कैन क्लियरली सी कि एक्टोपी एब्लेट हो गई है। थर्ड केस, खातून, palpitation, VT. So the first two ectopies, now sustained VT, exercise sahi, but it was sustained. That's the VT. Again, जो colleagues मेरे ज़ाहिर है इस इल्म को रखते हैं, they realize कि ये एक मखसूस सी जगह है जहाँ से ये originate कर रहा है। और सर ये पहचानना इसलिए ज़रूरी है कि अगर आप इसको सही नहीं पहचान सकेंगे तो हार्ट कहने को तो शायद छोटा स्ट्रक्चर है, लेकिन आप जब छोटा सा कैथेटर अंदर लेके जाते हैं और आपको एरिया नहीं पता होता तो आप पूरा दिन लगे रहें, रिजल्ट विल बी ज़ीरो। सो यू नीड ऑल दी टूल्स टू कम टू अ सक्सेस। और इसमें सबसे इंपॉर्टेंट टूल इज आइडेंटिफाई द ईसीजी, recognize the ECG. This tell you almost to the point जहाँ से इसका source है। So again same sequence, इस कैथेटर्स तो हम काफ़ी डालते हैं, लेकिन मैंने just for the explanation यहाँ से समझने के लिए अगर आप देखें तो now I've just shown a single catheter और this is in the RV आउटफ्लो एरिया। यहाँ पे अगर आप गौर करें तो मैपिंग सिस्टम में अगेन देयर इज़ अ सिंगल फोकस जहाँ से ये लगता है कि जो रेड स्पॉट है दिस इज़ द बुल्स आई टू बी ऑनेस्ट। और नीचे आप गौर करें तो वंस वी स्टार्ट एब्लेशन तो द एक्टोपी विल डिसअपीयर। अनदर केस इट्स वेरी इंटरेस्टिंग, ये एडवांस्ड ईपी स्किल्स हैं। This was one case which was a challenge for us. So ARVD diagnose हुआ, ICD डला, सारे पैरामीटर्स, लेकिन उसके बाद एक अजीब सा इसको VT होता था। And he was a very old patient for us. इमरान मजीद साहब के ज़माने से चल रहा था हमारे साथ, बहुत पुराना जाना पहचाना, बड़ा एजुकेटेड बंदा with all the facilities. वेस्ट में भी जा सकता था, इसके पास वसाइल थे जाने के भी। So we decided to go on. एक ARVC की ECG है जो कि आपको मैंने यहाँ दिखा रहा हूँ। So what we did was, he was having this slower VT, a very slower VT, लेकिन very terrible VT। अब ये VT ऐसा है नहीं कि आप इसको कार्डियोवर्ट करें, ये VT ऐसा है नहीं कि आप इसके लिए एंटी एरिथमिक बढ़ाएं। एंटी एरिथमिक बढ़ाते हैं तो उसके अपने मसले हैं, कार्डियोवर्जन इस पर करते हैं तो बैटरी खराब ज़ाया हो जाती है। So the only option was ablation, लेकिन the problem was that this was coming not from the endocardium and we realized कि ये शायद epicardial origin है। So this was the first ever case which we did with epicardial approach। So ये चूँकि this was the first ever for us and we were doing it, तो naturally थोड़ी सी हमसे भी हल्की फुल्की गलतियाँ हुई हैं। So यहाँ पे इंजेक्ट की डाई अभी जहाँ पे स्पेस थी ही नहीं, so this is the just below the pericardial space, but then on the next we went into the space। यहाँ अलबत्ता हल्का सा RV hit हो गया, but eventually we landed into the space। So now we are in the pericardial space and this is the ICD lead। So the next thing we did was, you can see the wire and then the catheters, और इसमें दिस इज़ अ बास्केट कैथेटर। यहाँ ये अब एब्लेशन कैथेटर है, दिस इज़ अनदर शीट। सो एब्लेशन कैथेटर है। नाउ वी आर ऑल इन दी एपिकार्डियल स्पेस एंड दीज पिक्चर्स आर साइमल्टेनियस, एपी एंड इंडो, बड़ी हेल्पफुल है, सिग्नल्स की मदद से हमें बहुत कुछ बताती हैं। इसमें आप लोगों को दिखाने का मकसद सिर्फ ये है कि अगर आप यहाँ पे रंगों पे गौर करें, ये हार्ट को बाहर से हम दिखा रहे हैं एंड दिस वाज वेरी हेल्पफुल, वेरी यूजफुल टूल। तो देयर इज़ एन एरिया जहाँ पे काफ़ी डिलेड कलर्स फिल अप हो रहे हैं। दिस इज़ प्रॉब्ली द एरिया ऑफ स्लो कंडक्शन
which we thought would be arrhythmogenic. So इसी को एब्लेट करके लाइन ड्रॉ की गई, जिसके नतीजे में एरिथमिया डिसअपियर हुआ. ये है एब्लेशन कैथेटर, एपिकार्डियल स्पेस, all along epicardial space. And the final, sort of final picture. I think ये शायद प्री प्रोसीजर था या पोस्ट था.
ये आपने लाइन ड्रॉ करने से पहले अजमत
सर
इधर
हाँ,
लाइन ड्रॉ करने से पहले आपने एंजियोग्राम किया था?
लाइन ड्रॉ करने से पहले एंजियोग्राम मुझे भी याद नहीं, मैं भी किया होगा, आई एम श्योर, या शायद उसकी पिक्चर नहीं है. लास्ट केस, एंड दिस इज वेरी इंटरेस्टिंग. सो 21-year-old gentleman, palpitation, we thought इसको VT है and fascicular VT. It would terminate with verapamil. Have a look at the tachy. So most of my colleagues would probably agree with me that by the look of it, shayad it's an atypical right bundle and it looks like ये LV, obviously LV है and maybe fascicular, but we're a bit delayed intrinsicoid deflection in V1. जब ये थोड़ा सा intrinsicoid delayed होना शुरू हो तो one tends to worry कि ये शायद clear cut conduction system से ना हो. So what we did was, इसके लिए हमने थोड़ी सी एक different approach मुंतखब की. So this is the first time ever use of an ICE catheter. We do have a machine with ICE and IVUS facility. So what we did in this case was, so we did a transseptal puncture, and with the help of this ICE machine, this is ultra ICE, not like the classic ICE with a TOE type of a picture, but still it gives you a very clear-cut idea of where the septum is, tenting is, and you can safely go into the left atrium. So we use this one, and then, okay, there we go. There's one more, yeah. So before that, so this is now we are in LV. Now this is the ablation catheter, the more whitish. That is the papillary muscle, posteromedial. This is all LV. That's the septum. This is the chordae tendineae. And now, so sir, this tool has given us an added advantage. Now, once we used to do all these ablations without the help of this tool, which is very much in use now in the West. Was there before, but because of cost effect, was obviously for us to do each case on it was obviously not cost effective. But what help it gives us is that यहाँ पे अगर अभी हमारे पास ये टूल ना होता तो यहाँ में ये पता ना चलता कि जो एब्लेशन मैं कर रहा हूँ ये मेरी एब्लेशन की टिप है. बाय द वे, इस वक्त चूँकि एब्लेशन ऑन हो गई है इसलिए जो कलर है ये चेंज हो गया, इट हैज़ बिकम वाइटिश बिकॉज इस टाइम हीट डिलीवर हो रही है. लेकिन अगर ये टूल आपके पास ना हो तो सिर्फ सिग्नल्स की मदद से आपको ये पता नहीं चलता कि आप एनाटॉमी में उसकी जो कैथेटर की टिप है वो एग्जैक्टली किस पॉइंट पे आपकी बैठी हुई है. ये टूल जब अवेलेबल हुआ तो यहाँ पे आप क्लियरली दिखा सकते हैं कि ये अब आप पेपिलरी के पास हैं या पेपिलरी से अवे है. इस केस में चूंकि जैसे मैंने सरफेस ईसीजी पे भी कहा था तो देयर वाज अ क्वेश्चन कि शायद ये इतना क्लियर कट कंडक्शन सिस्टम से नहीं आ रहा. सो यहाँ चूंकि पेपिलरी को हिट करना इट्स अ मूविंग स्ट्रक्चर, ए बी, ये एक राउंडेड टाइप या पिरामिडल टाइप स्ट्रक्चर है, कोई पिन पॉइंट जगह है नहीं. तो इसके साथ मदद ये मिलती है कि आप इसको पेपिलरी को भी पिन पॉइंट कर लेते हैं, पेपिलरी की एग्जैक्ट लोकेशन भी पता हो जाती है और आप इसके ऊपर रखें तो यू वुड रियलाइज कि यू आर हिटिंग द पेपिलरी मसल. सो दिस वाज एन एडिशनल टूल व्हिच वाज अवेलेबल टू अस. कलर्स अगेन, एज आई सेड, कलर्स ने हमें मदद की. यू कैन सी दिस वाज द साइड जहाँ से द रेड इज ऑलवेज द एरिया ऑफ इंटरेस्ट, और नीचे आप यू कैन सी के एरिथमिया इज गॉन. So with this, I thank you all, or I hope के
Azmat, just a quick question. Very nice presentation. What really was your message is that the area identification is the key, and the rest is a routine procedure. So in the area identification, as we were discussing yesterday, if you remember, the use of AI. The use of AI has been very helpful in identifying aortic stenosis patients from ECGs, established facts. So can we use AI to identify the area from which the arrhythmia is being generated? I think it is possible. And the next question in the same line is that CMR or LA strain, can they be of help for you in identifying the area?
जी सर, दोनों सवाल आपके जायज़ हैं. एआई का तो कल हम वही डिस्कस कर रहे थे, अभी तो उसने आना है. बट आई एग्री कि जब वो आएगी तो चूँकि उसमें काफ़ी सारी चीज़ें लोडेड होंगी, तो येस मे बी वो इसको हमें पिन पॉइंट करके कर सके. रोबोटिक तो यूज़ हुए हैं, मैंने भी देखी हैं, आई एम श्योर मेरे सीनियर कॉलीग्स ईपी वालों ने भी रोबोटिक देखी हैं. तो रोबोटिक तो मैंने खुद भी देखी है और बहुत पुरानी. एआई का इस्तेमाल इस कॉम्प्लेक्स साइट एब्लेशन में, जैसे एआई हर चीज़ कर सकेगा, शायद ये भी कर जाए. वो तो एट द मोमेंट मेरे पास उसका कोई डेफिनेट आंसर नहीं है. जो दूसरा सवाल है वो आपका बड़ा इंपॉर्टेंट है सर. वो ये है कि ये मैंने सिर्फ उसका आपको ना एक निचोड़ पेश किया. ये हम करते ही हैं कि हम इसमें ना सर हर टूल को यूज़ करते हैं. और लकीली ऑल गुड सेंटर्स हैव कार्डिक एमआरस. तो हमारे पास भी वी हैव कार्डिक एमआर, तो हम करते हैं इनका सर. हम एमआरआई करते हैं. ये मेरे जितने कॉलीग्स फ्रंट पे बैठे हैं ना सर, ये माशाल्लाह एफआईसी के ये माहिर हैं, ये हमें बड़ी हेल्प करते हैं. मज़े की बात ये है कि जनफरान से लेकर फिर मोहसिन तक और ये सारे, ये मैं इनको ईसीजी देख के बताता हूँ कि सर मुझे ना एलवी का ये एरिया चाहिए, तो फिर ये उस हिसाब से स्लाइसेस बनाते हैं और उसके फिर बताते हैं. लेकिन फिर ये कहते क्या हैं, ये कहते हैं यहाँ पे स्कार है. अच्छा सर, स्कार तो मुझे मैपिंग सिस्टम से भी पता चल जाता है. मुझे तो जैसे ही हम कैथेटर ले जाते हैं तो कैथेटर हार्ट में गया और जो लो वोल्टेज सिग्नल्स हैं वो स्कार है. ठीक, मसला ये नहीं है. मसला ये स्कार इतना भी हो सकता है, स्कार इतना भी हो सकता है. आपने हिट करना है रिदमिया को 1 मिलीमीटर बाय मिलीमीटर एरिया में. अब वो जो मिलीमीटर बाय मिलीमीटर है उसकी पहचान, कैथेटर की टिप तो अंदर है, वो तो आपको नज़र नहीं आ रही, या आपको सिग्नल नज़र आ रहे हैं जो सिग्नल्स माइन्यूट या फ्लोरो. लेकिन जो आइस मैंने बताई, आइस ये बताती है कि मिसाल के तौर पे एक ऐसी पहाड़ी है और पहाड़ी की टिप पे इशू है. अब मुझे तो ब्लाइंड हूँ, मुझे नज़र नहीं आ रहा, मेरा कैथेटर यहाँ हिट कर रहा है, यहाँ कर रहा है और इशू पहाड़ी के टिप पे. तो एडिशनल टूल आइस ये बताएगा कि मुझे पहाड़ी की टिप पे जाना है, तो आइस मुझे गाइड करेगा कि ये उसकी टिप है. तो आइस की गाइडेंस. सो ऑल सर, सरफेस ईसीजी 1, एको एमआरआई 2, फॉलोड बाय प्रोसीजर के दौरान इंट्राकार्डिक सिग्नल्स एंड मैपिंग सिस्टम जमा ऑन साइट आइस का एडिशनल टूल, जो आपको आइस आपको एंड पे बताएगा कि ये आपने चूंकि जाना इधर था तो हाथ पकड़ के आपको इधर ले जाएगा. दिस इज हाउ द मैकेनिज्म इज सर.
Professor Azmat, just a very common question from our side, because we are not EP people. Idiopathic VT and a VT arising from a scarred myocardium post-MI, इसमें जो आप एबिलेशन करते हैं इसके क्या डिफरेंस है और कौन सा ज़्यादा मुश्किल है?
सर वो सॉरी सर, मुश्किल का नहीं है मसला. जो इडियोपैथिक है ना सर, वो तो हम सब कॉलीग्स जो हैं, आमिर है, मैं हूँ, ये तो इडियोपैथिक तो दिस इज़ ब्रेड एंड बटर जो हम कर रहे हैं. जो स्कार है ना, एसेंशियली पोस्ट एमआई स्कार, उसमें 2-3 मसाइल हैं. एक तो ये पेशेंट्स जनरली हीमोडायनेमिकली भी अनस्टेबल होते हैं, इनके और भी मसाइल होते हैं. तो टेबल पे आपको अगर आपको वो वीटी चाहिए होता है जो पेशेंट टॉलरेट कर सके. अब पेशेंट टॉलरेट इडियोपैथिक को कर जाता है क्योंकि आपको 2 से 3 घंटे लगते हैं पहले. अब तो टूल्स आ गए हैं ना, सो उसका तोड़ खैर दुनिया कर रही है. देयर 2-3 स्टडीज, स्मैश स्टडी है जो अब हम भी कर रहे हैं. हम ये कर रहे हैं कि अब जो आईसीडी अफोर्ड नहीं कर रहा तो हम उसकी सबस्ट्रेक्ट एब्लेशन कर रहे हैं, यानी पोस्ट एमआई स्कार एब्लेशन.
और ये वो जो आपने ख़ास तौर पे बात की ना स्कार वाली, सो वी डू इट, लेकिन जिनमें आईसीडी नहीं अफोर्ड होती वीटी टॉलरेट कर लेगा, उसकी हम जाके स्कार को सबस्ट्रेक्ट मॉडिफिकेशन कर लेंगे. इट्स अ टीडियस जॉब बट वी आर डूइंग इट नाउ, दुनिया भी कर रही है.
और ये सारी री एंट्री सर्किट्स है ना जिसको आप करते हैं?
जी सर, ऐसा ही ऐसा ही.
Thank you very much. This brings us to the end of this session of electrophysiology. I am thankful to all the participants and chairpersons. Thank you very much, sir. Now, next up, we have session on adult congenital interventions. I'll request my colleague, Ms. Tamina Kazmi, to take over and moderate the session.